seat. I noticed everybody quieted down all at the same time, so that was my cue to come up here and start talking. My name's Aaron Kaczarski. I'm with the National Council on Alcoholism and Drug Dependence. We're co-sponsoring this event along with the Wellness Center here at Stockton College. Would you guys agree it's a pretty beautiful campus, right? We're in a good spot. I wanted to make sure that we thanked some of the organizers that have been working on this event for some months now. The first being the NCADD New Jersey advocacy leaders. If you're an NCADD New Jersey advocacy leader and you're in the room right now, could you just stand up so we can congratulate you for helping out? Thank you, guys. NCADD New Jersey also partnered with Mental Health Association New Jersey, NAMI, Parent to Parent, the New Jersey Association of Mental Health and Addiction Agencies, Seabrook House, and John Brooks Recovery House. So this was an event that really we wanted to bring people together because we know that's an important issue when we're addressing parity, and the fact that the parity law has been passed federally since 2008, and it's yet to be implemented. So what we wanted to do was bring individuals, advocates together to talk about these issues. What we're going to do today is we're going to provide an opportunity for witnesses that have sought either mental health or addiction services after the parity law was passed in 2008 and actually have been denied treatment and coverage. So what we're going to do is it's about those voices today. And what we did is we brought some experts in here on parity. At the end of the program, we put aside some time for you all to stand up and ask questions of the panel, of the expert panel. We have 2 microphones at the front of the room here. So as you're sitting there and listening to the issues and listening to the conversation, we encourage you to think about some questions that you might want to ask. We're going to have a couple volunteers go around. If you're not comfortable standing and asking a question from one of the microphones, we're going to have some index cards that are passed around when it gets closer to the question and answer time. So that way you can write down your question, and we'll work to get as many of those questions in as possible at the end of the night. So thanks everybody for being here. We've been working on this for a while, and it's good to see a packed house full of people. And what we're going to do is we wanted to bring in a parity expert right off the bat to kind of go over the basics and why we're here today. She's a good friend of ours. Carol McDade works with Capital Decisions in D.C., and she was one of the main lobbyists for the parity law in 2008. So the perfect person to answer your questions at the end of the night. Without further ado, please welcome Carol McDade. Thanks.
Well, good evening, everybody. Got to bring the mic so I can. My name is Carol McDade, and I'm a woman in long-term recovery. And long-term recovery for me means that I've been alcohol and drug-free for over 15 years. Thank you. And my recovery has allowed me to become a wife, a stepmom, a small businesswoman, and the reason I'm here tonight, like many of you, I'm an advocate for recovery. I'm going to kind of just tee things up for tonight and give you some of the very basics about what the parity law is, why there are problems with it, and why we really need your continued help and support. And while I may have been one of the advocates in the trenches tolling, I would be remiss if I didn't say the driving force and the spiritual guru of the parity and recovery movement in this country right now, Patrick Kennedy. So let's talk a little bit about what it is and why we need it. So you'll hear us say parity, you might hear us say an acronym called MAPIA. What this is, it's referring to a law that passed in 2008, thanks to Patrick's work and the work of his father in the United States Senate, that requires health plans to treat addiction and mental illness like other medical conditions covered under health insurance. That law passed in 2008. It became fully effective in 2011, And we were able to get provisions that also require parity. And when I say that, I mean that diseases of the brain should not be treated any differently than the diseases of the body, that there's no medical reason for the disparate treatment. So when we talk about parity, what we are referring to is that these conditions, behavioral conditions, addiction and mental health, have to be equal to the treatment and health plans for other medical conditions. And if you look it up in the dictionary, that's what it says, the state of being equal, and especially regarding status or pay. And the pay part is very interesting, and we're going to get into that tonight. Many of you have probably had trouble getting your behavioral health care needs paid for, and that reimbursement rates are a part of this law. So why did we even need this law? There has been historic discrimination in access to care for mental health and addiction in this country. What do I mean by that? You have to, historically, you might have a $10 or $20 copay to go see a physician, and then on the behavioral health side, you might have had to pay half the cost of the visit as your copay amount. So there were uneven out-of-pocket spending amounts that consumers were required to pay. And one of the issues that I think people really aren't aware of, and it's really just an outrage to me, is that individuals who have addiction, severe addiction and mental illnesses, die on average nationally 30 years earlier than people without these conditions. Let me repeat that so people kind of wrap their brains around that. People who have severe addiction and mental illness die on average 30 years sooner than people with other medical conditions. For some people, that's nearly half of a life cut short. If this was another illness, people would be rioting in the streets for access to the care to keep the life expectancy equal. But when it comes to addiction and mental illness, there's been such stigma and discrimination, as I know many of you know all too well, that these kinds of things get buried and they're not talked about. And the reason why we're really here tonight, so we passed this law to address this historic discrimination in access to care and the fact that consumers were having to pay more out of their own pockets than they do for other medical conditions. So we get the law passed in 2008, becomes fully effective in 2011. But as most of you know from your civics class, getting a law passed does not do the job itself. You then have to get regulations that implement and actually actualize the law in people's lives after that. And that's what we're here tonight to talk about, is that the final rules that actually operationalize the law. There have been interim rules that are issued, and they do have the effect of law, and plans are responsible for implementing parity today, but they need to be clearer and they need to be stronger. And so the final regulations have not been implemented. There was an executive order. Patrick did a lot of work on this in February after the Newtown tragedy, and it requires the government to issue a final rule by the end of this year. But we need all of you to help us advocate for that and for the strongest rule possible. And so that's one of the reasons why we're having these field hearings all across the country. This is the 13th one. So what does the law do? And I promise this is going to be the only really gobbledygook, boring thing I'm going to go over. The law says that health plans have to offer 6 classifications of benefits. Nothing real, unusual here. Inpatient, in and out of network. Outpatient, in and out of network. Emergency care, and prescription drugs. What we've been finding as we've gone around the country and met with people like you is that because intermediate levels of care, and what I mean by that is an umbrella term for things like intensive outpatient, partial hospitalization, and residential, they're not being covered because they're not explicitly named as one of those 6 classes in the regulations. And so we're asking that by the end of the year that these intermediate inpatient in and out of network will be added in those 3 areas. So what are the big issues that we need to get resolved between now and then? And we need your help on this to help demand change and explain why we need these things. Well, the first thing, and this probably doesn't come as any surprise to anyone, we need transparency and disclosure of how the plans apply various kinds of medical determinations on medical conditions, because parity is all about comparing how a plan treats medical conditions and how they treat behavioral health conditions. And if we don't know how the plans apply it to other medical conditions, we can't do a parity compliance check. And the plans have been very reluctant to provide it. In fact, they're not providing it at all. And we need to make sure a final rule says that they must provide it so that parity compliance testing can be adequately done. There's another unique thing in the federal parity law that is not in any of the state parity laws, and it's this $5 word phrase called non-quantitative treatment limits. And all that means is that you can't just have parity in how much people pay for their benefits. You also have to have parity in how the plan medically manages those benefits. And for those of you who are providers, those are things like utilization review and prior authorization and having to fail first at outpatient before you get residential or inpatient. Those kinds of things are those hidden barriers to people accessing care. And what this law says is that they have to be done on par with the way that they manage medical benefits. And the last, and probably one of the most important things and the biggest violations we've seen around the country are the issue around scope of service. And what we mean here is that if a plan offers a huge and vast array of levels of care and types of services on the medical side, they can't then on the behavioral health side say, well, we're going to offer just prescription drugs and outpatient. So if there is a nice array of benefits on the medical side, we believe that this law requires that there be an equally wide array on the behavioral health side. And we are very hopeful, we feel good about the fact that we will get some of these the additional levels of care included in the scope of service requirement. So that's in a nutshell what the parity law requires and what we're trying to accomplish. I did want to mention that parity is also applied in the Affordable Care Act, the health reform law that goes into effect in 2014. And we will have to, see how the final rule goes to see how parity will be applied in the Affordable Care Act. There have been several lawsuits that have been filed. I'm happy to report challenging violations of the federal law. They're going in a positive direction for consumers and families and providers, which is great news. And I see these continuing as the year goes on. I wanted to, before I close, I wanted to make sure that you all knew there are resources out there to help you. We need people to file appeals of denied claims. In that first website, there's a consumer and provider toolkit that helps you know how to do that. If we don't complain when health plans are breaking the law, it continues. And so we need your help in making sure we push back when this law is being broken. The other resources there are places where you can file complaints depending on what type of health plan you have. And that is it. Now you get to have the important part of the night, which is we hear from all of you so we can help you make sure that you get the care that you deserve. Thank you.
All right. Thank you, Carol. Whenever I have questions about parity, it's good to kind of check in with Carol. And also, if you go visit Carol in Virginia, you eat some of the best barbecue you've ever had in your life. So. She always makes me feel welcome. The second person that's going to be on the listening panel tonight, we wanted to make sure that we had an elected official from New Jersey here. Senator Robert Singer is the co-sponsor of the state parity bill, so he's going to talk about some of the differences between the law that Carol just talked about and the state parity bill. So please welcome New Jersey Senator Robert Singer.
Thank you very much. Thanks for having me here tonight. I just wanted to share a few brief thoughts before we open up the panel from the state's perspective. Follow the money. Don't ever kid yourself this is a big money issue. I sit on the board of a 100-bed mental health hospital. if you take a look what has happened systematically in the state of New Jersey, we have closed all state facilities. And of course, many of them were antiquated and need to be revamped and everything else like that. But we closed them down and we said, don't worry about it. The money is going to follow the patients. The money is going to come to the counties, municipalities. And I was told that by governor after governor, and the money never came. I can tell you that screening units, PES units throughout the state, the busiest PES unit in the state of New Jersey is in my hometown of Lakewood. Busiest in the entire state. And in any given time, in any given hour of the day, you can come to Ocean County and go to one of the hospitals and you can see a teenager sitting in a gurney with a hospital gown on with their parents waiting for one of the 18 juvenile beds that services Ocean and Monmouth County to get in there to get help. And then, of course, it's only short term, because if it's long term, there's no place to go in New Jersey. They want to send you out of state. And God forbid you're on a state Medicaid program, just like that, there is no money for that. So parents find themselves trapped. And the solution that many providers say is, we're going to service your child with outpatient, no matter what the problem is, and then we're going to send them back to the same high school or area they were at where the same problem started. And it might be drugs, and it might be alcohol, it might be anything else like that. So we have buried the issue because the money issue is a big money issue. And the second issue, and what you're hearing tonight, is lack of advocacy for one reason. Nobody raises their hand and said, by the way, there's mental illness in my family member is a drug addict or an active alcoholic or anything else like that. It's a quiet thing. And because we don't raise these groups and we don't come forward with these groups, politicians kind of go where the money is and where the power lies. And they kind of answer those questions instead of dealing in the trenches with those hard issues. And, you know, I can tell you from the perspective of what is happening in my county of Ocean and Monmouth, I represent, 3 weeks ago, five people died of heroin overdose. 5 young people in 1 week. We had another death last week. And that doesn't include all those that are coding and haven't passed away. So if we take a look at the issue, which is epidemic proportion in the state of New Jersey, which is a hidden issue that no one even talks about, of what is going on in the drug aspect of things, try to go and have someone have medical detox. Insurance companies won't pay for it. It's virtually impossible. So their solution to everything is social detox. There's a big difference in that. So I know we're going to hear from people tonight and hopefully gain some knowledge in that. But understand something, that it is a money issue, that insurance companies are coming to the table kicking and screaming, that most people have no idea what their insurance company covers for mental or addiction until it happens in their family, and then all of a sudden find out there's virtually nothing. And the other thing about it, we just don't have the facilities here. We don't have the facilities, and we don't make the effort. And I'm so concerned because when I have a high school in my county called Heroin High, and the fact is that we talk about this issue and people look like, what are you talking about? And that we can calmly talk about 5 young people dying in 1 week and thinking, you know, this is a problem. And by the way, I live in the only urban age city in Ocean County, Lakewood. So everyone presumes, since my school district, my public school district is 85% minority, that all the drug problems and all the other problems are in my town. It can't be in the other 32 municipalities because they don't have a minority population. It must be in Lakewood. Except Heroin High is not in Lakewood, it's in Toms River. And the issue of drug schools in my county is not in Lakewood. It's in other towns because drugs follow the money. They don't follow races, they follow money. And very, very honestly, that's why this issue is so hidden, because people expect this to be an issue not in suburbia. It must be only in inner cities, and it's not. And when we talk about all these mental health issues of young people, and I'm especially concerned about young people because those are the ones that are left out of this whole thing, we still talk about 18 beds servicing 2 counties, the same 18 beds that have serviced 2 counties for 25 years. 25 years. And it's the same story, by the way, statewide. And until we start raising the attention and start talking about putting dollars into mental health, and by the way, the other aspect of this, the other shortcoming is there aren't enough psychiatrists. You can't find them to work in hospitals. They don't want to do it because they're so overwhelmed in their private practice. And you can't find juvenile psychiatrists. I mean, just, it's for love nor money. It's a big problem. And we don't talk about this with UMDMJ saying, wait a second, we've got to work on this issue. This has got to be a priority issue of graduating more psychiatrists that come back and practice in the state of New Jersey that help our young people and our other people. And the last thing I just want to talk about is I also represent the largest senior citizen area of the state. And we continually forget that New Jersey is the second oldest state in the country. The only state older than New Jersey is Florida. And with that aging population comes mental health issues. It's a fact we have to live with. And if you take the mental health issue of seniors and dealing with that, that's also the other issue. And maybe we can raise that attention. You know, if you deal with seniors and we get ARP on board, people like that, you'll find a great advocacy group that all of a sudden legislators pay attention to. All of a sudden there's a big voice. And too many times we don't talk about that because I'll tell you, you know, God bless women, they outlive men, but because of that issue, alcoholism and drug abuse in the senior communities is very active. But it's not talked about because doctors are afraid if someone comes in that has a problem and they report them, that the word will get out, don't go to see Dr. such and such because he reports you. So these are some of the issues we're dealing with that we have to come out of the closet about and talk about. How we deal with the aging population, the problems of mental health issues and drug addiction and alcohol addiction. How we deal with our young people and start to understand it's a big money issue that we have to say it is time for us to care for people the way we should be. Thank you.
Thank you, Senator. Just two things really quick about what the Senator and Carol had to say. Carol had mentioned those resources, and we took them down from there. But those resources are in everybody's program. If you haven't grabbed one, make sure that you grab one. So that way we can give you if you've experienced discriminatory public practices as a person that's seeking mental health or addiction services in the state, we want to give people an avenue to have that voice heard. In New Jersey, we have an advocacy leadership program as well where we're building an army of people that are speaking out about their recovery, both in mental health and addiction, and we think that it's making a difference. Those applications are out in the front as well, and so there's some more information about that. Our third panelist, our listening panelist, probably doesn't need too much of an introduction. I was fortunate when I lived in Rhode Island to be represented by former Congressman Patrick Kennedy, and as a person in recovery since September 6th of 2003 from alcohol and other drugs, it was really nice to have an elected official that understood what I was going through, as not only as a person in recovery, but when I went to go seek services in the state. He's a mental health and addiction recovery champion. Ladies and gentlemen, Honorable Patrick Kennedy.
Now I'm your representative, so to speak, down here in New Jersey. I just follow you. Follow you, Aaron. I want to thank you, Aaron, for your great leadership. You are showing how someone in recovery can take their recovery and help allow an opportunity for others to recover, not simply because you are working your own program of recovery, but you're also a good citizen. And many of us who are in 12-step groups often don't make the connection between following our own recovery and making sure we protect it, but also being citizens. And that means, as the Senator pointed out so eloquently, showing up and giving a voice to these issues. Because as the Senator pointed out, the main problem we all have in the discrimination that exists against people trying to practice medicine in this field, or in the public funding for this field, is that there is no advocacy. Now, the advocacy for the whole state of New Jersey is probably in this room, right? So you all, I'm obviously speaking to the choir because you're all already active. But for those of you who are just learning about this, I'd encourage you to follow Aaron's admonition and sign up. When you leave here, sign up to become an advocate. because that does not violate any of the principles of the program we all know in 12-step recovery, because that's your other program. This is the program of getting results with your tax dollars. So let me thank Carol for her great overview. And let me just point out what this is about. Senator Singer, I don't know whether to out him or not, but he's a Republican. All right, so I just want you to know, so you get a little background, these diseases, you know, they don't affect Democrat households or Republican households. They affect all American households. And it's worth my noting that my co-sponsor on mental health parity is a Republican by the name of Jim Ramstad. And my father's Republican co-sponsor is Senator Pete Domenici, and it was President George W. Bush who signed the parity law into effect. Okay? So, you know, I want everybody to know that. Now, let me just quickly encapsulate what Carol said. If you had cancer, you wouldn't expect to have to wait till you had stage 4 cancer before you got treatment. That's how today we reimburse for mental health issues. We wait until you're at death's door before we say you're worthy of treatment. If you had diabetes, do we wait until we have to amputate your legs or you go blind? Hopefully we don't. In fact, our healthcare system reimburses for all kinds of preventive care. You know, you get your insulin, you get your access to primary care doc, you get your test strips, you get all of that covered. Now, I have 2 chronic illnesses. I have asthma, and I get my inhalers. I get my primary care doctor, takes care of it. You know why? Because they don't like me showing up with asthma attacks in the emergency room. And I've been in the emergency room plenty of times for my asthma. So they give me medications to keep my asthma stabilized. They give me not only fast-acting inhalers, they give me long-acting inhalers. And they don't question if I do have an asthma attack that I need care, and I never have to worry about my insurance reimbursing for it. Now, my other chronic illness is that I am in recovery for addiction, and that chronic addiction, that chronic alcoholism that I have is not treated the same way. And so I want you to understand the difference. Now, when you have an addiction, if you go to the hospital, they think you're cured. So if you do manage to get treatment, you probably run up against your treatment limits, and then you leave and they say, it's your fault if you get sick again. Now, do they say that to the diabetic who also drinks or eats chocolate cake and has a diabetic shock? Do you think they send them outside the ER and say, oh, wait, sorry, you're a moral failure. Get out of here. No, they don't do that. So my point is that, you know, as big a challenge as we have outside, we also have to change our own perceptions and hidden attitudes towards these illnesses. Because when you're in active addiction, you're not a very happy person, and you're not a very happy person to take care of. All right? So we are inviting of a lot of these stigmas and stereotypes, but we need to address them straight on. And I want to thank all of those who are going to be testifying tonight for helping to break the cycle of silence. Because the biggest killer in this illness is the isolation and the silence that accompanies these physical illnesses. And they are brain illnesses. But we don't treat them as physical illnesses. We don't treat them as medical issues. We treat them as moral issues and as character issues, not chemistry issues. So that is essentially what we're up against. I want to thank you all in advance for your testimony. We're going to listen to our panels and offer some insight. But why are we all here? We're all here so we can change this situation that the Senator and Carol outlined for you. So that for your kids and your family members in the future, if they need health care, you know, we have a checkup from the neck up. Not just blood pressure being checked and whether you're high risk for cholesterol. Right? Maybe it'd be good for us to check whether you're high risk for addiction. Maybe it'd be good for us to check whether you're high risk for depression or psychosis. You know, maybe it'd be a good thing to do those things. And right now in our country, can you believe it? In this day and age, we don't check the most important organ in our body. I mean, I'm not making this up. It's pretty shocking when you think about it. The most important organ in our body, and our whole healthcare system ignores it. So we have a lot of work to do. And I'm so happy you're here tonight to help us get underway here in New Jersey. Thank you all for coming. So we have our first panel, and it's in front of me at the desk here. But before I acknowledge them, let me acknowledge the reason I'm in New Jersey, and that's that I met a Jersey girl. A Jersey girl. So for those who know that they're on the first panel, Lori and Cass and Jared and AJ, and I think Lori and Cass are our first panel. Am I right, Aaron? Yep. So are they here? I'll have them introduce themselves and thank them for coming and welcome them here. Give them a great warm welcome.
I just want to give these to you first. I'm Cass Foster.
Yes.
From Parent to Parent.
Great.
This is yours.
Thank you.
The testimonies are inside.
Great.
Okay, great, thank you.
Thank you very
Senator
much.
Singer.
Thank
nice
you.
to see you.
Good seeing you. Thank you.
I just say, I'm happy to campaign against Senator Singer if it helps him get reelected. I just want to let him know. Isn't he terrific?
Yeah.
Isn't he terrific? Thank you all for coming, and please begin.
Okay, my name is Cass Foster, co-founder of Parent to Parent. We lost our 27-year-old son, Christian, in 1997 while he was waiting in line for a bed to become available for his drug addiction. Well, Christian died while waiting. So, the Wellstone-Dimitri Mental Health and Addiction Equity Act was passed by Congress and signed into law by then-President George W. Bush. That was in the year 2008. And Patrick Kennedy co-sponsored this bill, and he's become a champ into seeing that the bill is enforced and implemented the same way as any other disease. I am here today as a voice for all parents that have experienced discrimination, civil rights violations, and have become victims of their insurance companies while trying to save their child's life. Imagine sitting in a residential treatment facility with your son or daughter and being told that they are not eligible for treatment because the insurance company has a policy that one must fail outpatient first before being accepted into residential treatment. This is happening every day, and parents are frustrated and individuals are dying. The worst part that parents hear is that their loved one is suffering with a life-threatening disorder, and the insurance companies are saying it is not a medical necessity. The same insurance company will pay for heart disease, hepatitis C, and other physical conditions that were the result of the drug use. Parent to Parent has spoken with numerous parents regarding the lack of empathy they receive from their insurance company, even after telling them that their child or young adult is going to die if they do not get help. We're losing a generation of young people who are suffering from the disease of addiction and or mental health disorders. Why do we continue to pay high premiums only to be turned away when help is so desperately needed? One dad told me his insurance company had become a nightmare. Sadly, his son died. We can no longer accept the discrimination and the violation of people's civil rights. We have grieving support groups where I work. Here are the obituary books that Kathleen Dobbs started in 1997. A final rule must be written before any more parents have to bury their children. We will continue to stand together as one voice.
My name is Lori Zeiders. I'm the parent, I'm the mom of a son with addiction. My testimony tonight illustrates how insurance companies discriminate against people with addiction by denying long-term, inpatient rehabilitation despite doctor's orders. My story begins almost 2 years ago to the date, when my son was 15 years old. This is when his addiction started to surface and take control. His decline into prescription pain medication and heroin abuse began that summer. It started with heavy use of marijuana. In an effort to get him back on track, we enrolled him in an Outward Bound program, but that failed. He was sent home early because of defiant behavior. When he got back, we heard rumors that he was using more than just marijuana, and we suspected as much. He was drug tested at a lab on 3 separate occasions. Results were positive for marijuana, but nothing else. He became unmanageable. Foul language, destructive outbursts, extreme disrespect, missing money, police intervention were the norm for us. He was failing in school, and because of his conduct in school, officials banned him from the day program and put him into a night program, which he routinely skipped. He was losing weight, complaining of nausea. His breathing was irregular. The police eventually referred us to a mobile response service for help. A youth care manager was assigned to us, and she arranged for a counselor to come into our home once a week on a weekly, for 18 weeks. Throughout all this time, I should add, my son was under the care of a psychologist and a psychiatrist for pre-existing behavioral issues. By midwinter, we were in crisis mode. My son was hospitalized at a behavioral facility, which we chose because his psychiatrist was on staff there and knew his history. He stayed there for 7 days because that's all insurance would cover. While he was there, he was diagnosed with ODD, ADHD, possible bipolar disorder, cannabis abuse, and opiate abuse. The clinical team recommended that he enter an intensive outpatient, an IOP, immediately after discharge. When my son returned home, he looked and acted much better. He sincerely wanted to avoid drugs, and he wanted to rebuild his relationship with our family. But despite his best intentions and our efforts to help, within a couple of days he relapsed, and the cycle of destruction began again, and his drug use was getting worse. Nevertheless, we took him to an IOP facility for an intake evaluation. Despite his diagnosis and doctor recommendations, Magellan, who does administer our behavioral component of our insurance plan, initially denied this treatment. The residing doctor appealed, and Magellan did reverse their denial. But after 10 days of treatment, my son was discharged from the program because of disruptive behavior and lack of motivation to stay clean. His diagnosis was similar to the one before. Other than obtain a youth care manager, which we already had, the IOP facility clinicians made no recommendations to us. A month later, I discovered that my son had stolen most of my jewelry and cashed it in for pennies on the dollar to buy heroin. Later that day, I pressed charges, and the next day, he was hospitalized for a second time. This time, my son confessed that during the past month, he had been taking Percocet and Xanax on a daily basis. He had been snorting a bag of heroin a day for about 2 weeks at that point. He continued to smoke marijuana, and he admitted to using mushrooms and cocaine. Because his drug use was so extreme and he had comorbid psychiatric issues, the psychiatrist recommended that he be placed in a long-term residential treatment facility. The psychologist treating him agreed with this decision. So I made arrangements for him to go to a rehabilitation center in Florida. It was called 12 Oaks. And the psychiatrist contacted Magellan for pre-authorization. I picked my son up from the hospital and began driving him to the airport. I'd spoken extensively with 12 Oaks, and considering my son's diagnosis and history, I didn't foresee a problem with the insurance company. En route, the psychiatrist called me to say that Magellan had denied my son this treatment because it didn't meet their criteria for medical necessity. They based this decision on a criteria that was in the American Society of Addiction Medicine, ASAM manual. I put him on the airplane anyway because he was so sick, and long-term rehabilitation was our only hope. 12 Oaks attempted to get Magellan to authorize treatment, and again, it was denied. They said he was detoxing when he arrived. He had somehow hidden a Percocet and had taken it that day. My son ended up spending 20 days there. He was diagnosed, as before, on opiates and cannabis, and he was abusing a host of other drugs. He needed more extensive treatment than 12 Oaks could provide, so his treatment team recommended that he be placed in a structured and secure facility where he could continue treatment for addiction while learning to manage his behavior. We were referred to a place in Montana, the Wilderness Treatment Center, where he stayed for 60 days. He thrived there and completed the program. After that, my son spent the next 7 months at a halfway house, which is what the Wilderness Treatment Center had recommended as his step-down program. He was in a group setting where he had daily group meetings, counseling, and he learned how to use and implement the 12 steps. Magellan only paid for 2 weeks of all of this treatment. Not only did rehabilitation provide my son with the tools that he needed to fight addiction, but it also helped to reveal and diagnose the full nature of his illness. My son, I'm happy to say, is much better now, but he could relapse. I'm not sure what we'll do if that happens. Now, our insurance company, our insurance plan says the benefits for inpatient alcohol and substance abuse treatment are the same as any other illness. And the Mental Health Parity and Addiction Equity Act states that insurance companies cannot legally regulate mental health and addiction treatment in a way that's more restrictive to other illnesses. Well, clearly, our addiction treatment, our benefits for addiction treatment were not applied as they would have been for a physical illness. And the practice of overriding treating providers' recommendations is certainly not done where physical health is concerned. Each of the denial letters I received stated that the insurance company's assessment was made for the benefit of coverage purposes only and couldn't supersede the professional judgment of the provider. So it sounded like to me, what they were saying is that I could go ahead and take the provider's recommendations, but they wouldn't cover it if I did. Well, they did override the doctor's professional judgment. It was the treating provider who recommended rehabilitation in the first place. Magellan allows post-service appeals. The burden of proof is on the patient, or in my case, me. I've spent countless hours on the phone with the insurance company. It took a great deal of time and effort to gather records Magellan requires to support an appeal. I bought the ASAM manual they use and poured through it. You know, when I had to ask for all these records, it dawned on me that not only did Magellan override our doctor's recommendations, their physicians made medical decisions about my son without even considering clinical data and other relevant information. And they didn't even contact me. You know, plus, to use the ASAM manual, detailed information about the patient's history and condition must be considered. Magellan physicians are not using the manual as it was intended. As for approved inpatient drug and alcohol treatment, 2 weeks is the magic number. While trying to find treatment for my son, I talked to many facilities and asked about insurance coverage. Most of them said that I should not count on more than 2 weeks of coverage, and that's what happened. Our benefits were cut off after 2 weeks because we didn't meet the criteria for medical necessity. This time limit is not based on ASAM criteria. Rather, it appears to be a pre-established time limit. My husband and I have attended numerous Narcotics Anonymous meetings, and we've talked with many parents of teens with addiction. The stories are heartbreaking, yet they're all similar to the one I just told. Aside from the tragedy of addiction itself, an experience that's common to almost every one of us is the financial burden. Most of us have struggled with the bureaucracy of the insurance company, which is designed to stonewall and discourage attempts to gain coverage for the disease-ridden family member. People go to extreme measures to pay for treatment themselves because insurance will not cover it. In our case, we spent over $51,000 out of pocket. We had saved this for our son's future. But at least we had that. We've met people who've taken out second mortgages or other loans to pay for treatment. We've met people who've had to downsize their home to pay for treatment. And worst of all, as I'm sure there are many others who've not been able to afford treatment at all. I thank you all for your attention to this very serious issue.
You're an insurance company's worst nightmare, you guys.
Yes.
And, you know, you're such a remarkable parents, and you do what any other parent would do, but this extra step of just taking it upon yourselves to fight this fight is just so remarkable to all of you. You know, all I can say is the new law gives you now legal standing. And as Carol mentioned, we're going to be able to bring class action lawsuits in the future. So in the past, Cass and Laura, you know what they counted on is they counted on you going away. And they also, if they knew they had to settle with you, that they had a stipulation to do it in secret, in private, because they never wanted your stories to get out. The reason Carol has mentioned public disclosure is because, for two reasons. One, we ought to be able to track whether an insurance company imposes any higher treatment limitations on mental health and addiction as compared to other physical illnesses. And the only way we can measure is if the disclosure is public. That's not hard for anyone to understand, is it? I mean, in other words, you know, insurance companies don't have to worry about covering their tracks because they have no tracks to cover. So our first job is to get public disclosure, because there's something about the light of day that really panics them. because what the light of day does for the parents and the moms is it gives you the notion that you're not alone, because you know you're just like all those other mothers that have seen their children go down this road and be denied, denied, denied. And two, now that gives you legal standing to take your case and not have to fight it alone. So what I love here is that you're all together. And isn't it wonderful in a disease that's so isolating that all of you can be there not only for each other, but you can all support each other in this common struggle against the insurance companies who are denying treatment for your children. I just want to thank you for that courage.
I just want to, first of all, the congressman is so gracious and so passionate, I may have to change parties. Don't clap too loud. Let me just share two brief things with you. You know, I go back a long way with addiction services, and I've been in the legislature for 26 years. Years ago, insurance companies originally used to treat addiction based on if you had a 30-day plan, a 60-day plan, or a 90-day plan. So we had a host of facilities in the state of New Jersey all open up because your insurance company would pay 30 days and you had an addiction, you went in for a 30-day plan. If they paid 60, you went in 60-day. It was not based on medical, it was based on what your plan played. When that stopped, when insurance companies said, wait a second, we don't have to do this, people won't complain, all these places went out of business. And there was a whole host of them around the state. The other issue is, when you talk about Magellan and things like that, third-party administrators usually do the administration for self-insurance plans, which a lot of big companies have. Their job is to deny. That's their whole purpose, keeping costs down so that the self-insurance plan doesn't have a problem. So the intent is not to help you. The intent is not to pay. And that's part of the problem with the system, that we have to break that philosophy. The philosophy is, how do we help you? How do we make things make sense? How do we find services for you? Isn't it a little bit of a tragedy that here as a parent you couldn't find any place in New Jersey to send your child, that you had to send your child to Florida or Montana or Pennsylvania or Massachusetts, all around, because New Jersey has discouraged this from opening, have kept these facilities really out of state for a lot of reasons, financial reasons, so that there is no place to send, so that, for argument's sake, during that period of time when your child's there, you can visit. You can have contact. You don't have to fly out to Montana, anything else like that. So part of it, our obligation here as a legislature, is to see that New Jersey starts to meet those needs by allowing those facilities to open up and nurture them in New Jersey, so that when a parent has a problem, it can be serviced right here in our state and doesn't have to leave the state.
I was wondering, Cass, whether you could read some of the obits, because most people don't acknowledge when someone has died of this disease because they can't understand, they can't see it. And I want to just say to all the parents, when we did our initial parity hearing, it was one of the most powerful things that you all did. Yeah. And that's provide those obits. Yes. Because this is claiming the lives of so many people, and what's more tragic than even losing the life is the fact that no one acknowledges it. And so I want to thank you for this, because you're putting everybody on notice that you're not going to forget them, and you're going to fight for them. And I want to acknowledge what important work it is that you're doing by making sure you keep those memories alive. But I didn't know whether you could read a few for us. I know you've compiled quite a few books there.
All right.
This is a 25-year-old from Dennis Township. Joshua, 25, of Dennis Township, passed away suddenly on December 31st, 2012. Josh attended Dennis Township School and Middle Township School. He played basketball at the Dennis Township Rec and Middle School, High School. He was a veteran of Operations Iraq Freedom, serving in the New Jersey National Guard of Woodbury. He enjoyed playing with his nephew Dylan. Josh always said, "I've lived life to the fullest with no regrets." Josh was preceded by his grandparents, Howard and Betty, Raymond and Eleanor.
He is survived by his mother, father, sister, nephew Dylan, his dog Raiden, and many aunts and uncles and cousins.
Thank you. I want to, you know, in reading that obit, you also acknowledged his service to our country. And it's important that everyone understands that 72% of our returning vets from Iraq and Afghanistan will never darken the hall of the VA in their lifetime. 72%, which means most veterans are only going to get their care, especially for these quote-unquote invisible wounds of war. You can't see them on the outside, but because they were injured, traumatic brain injury, trauma, they come back, they need the services, mental health services. And if their insurer treats them like they treated your sons, you know, that's unbecoming of our great nation, that we cannot provide the necessary health care for the wounds of war suffered by our American heroes on all of our behalf.
It's grown to another book. It was only 2 in 2007.
Yeah.
It's now 3.
And this is Sue Foos-Bowanamo. This is her son in here. Died of July of 1997, and my son Christian died in June of 97, and this is what brought us together. And Kathleen, fortunately, hasn't lost a son, and she is capable of doing this, which is a sad thing, but it keeps growing. The books keep getting bigger and bigger.
Well, all I would
So-
say to you is, imagine if we treated these illnesses like these other chronic illnesses, where you would treat it early. I mean, how many of us take for granted we get screening? We get breast cancer screening, prostate cancer screening, skin cancer screening. You know, we're on Lipitor 20, 30 years before we even think of getting old enough to have a heart attack. But we're not going to treat in an early and preventive way, aggressively. We're not going to treat these illnesses. This is shocking, shocking in our country that you have to be carrying this message the way you have. But thank God you're there carrying this message. Let's give another great round of applause.
Witness table.
Good evening. My name is AJ Sinercia, and I'd like to tell you a little bit about my story surrounding discrimination based on insurance inequality while seeking support for mental health or addiction services, a civil rights issue that I hold near and dear to my heart. I'm a young person in long-term recovery, and what that means for me is that I have not used a drink or a drug since November 5th of 2010. I'm currently a recovery advocate for Young People in Recovery, a nonprofit organization where I serve on their executive committee as research committee chair, and I also serve as chairman of our Washington, D.C. chapter, where I currently reside. I'm also an alumni of this fine institution, the Richard Stockton College of New Jersey. And it is a privilege and an honor to be here before you today. To get right into it, during my junior year in 2010, I once again found myself withdrawing from my college courses because of the unmanageability that addiction had caused me in my life. When I went away to treatment this time, I did the intake that they do when you get there, and the intake coordinator came up to me afterwards and notified me that I would only receive 3 days of inpatient treatment. It was a bit shocking. Well, it wasn't a bit shocking. It was shocking. There was a lot of emotions that I had to go through. I was nervous, and most of all, I was scared. I used 4 different substances every single day for years before I went into that treatment center. And you're telling me, or this treatment center, or my insurance company was telling me that 3 days was enough to detox yourself from 4 different substances in which you used every day for years. It's mind-boggling to me. It would have done me more harm than good if I was to be released. You know, still hurting, still going through withdrawal, to be released back out to where I used, to where, you know, I did the things that I did. It was kind of a no-brainer of what direction I would have gone to in order to alleviate the pain that I was going through. Thankfully, though, I had secondary insurance. However, when they ran my secondary insurance, I dodged possibly the biggest act of discrimination against me that I've ever come across in my life. And that was the fact that, you know, one of the 4 substances I used every day was the drug of alcohol. If the insurance company picked up an additional 8 days, but only because I went into there having drinking alcohol. If I had not put down alcohol, or if I had not gone in addicted to alcohol, they would have picked up 0 days. The idea behind this notion that one drug is above another, or different from another, or that one drug needs special attention while others don't, is sickening to me. You know, I left treatment still in shock, or, you know, after 11 days, I was still shaking. I hadn't slept in 11 days. Could you imagine what would have happened to me if I left in 3 days? Other chronic conditions, hypertension, asthma, diabetes, they're not treated in 3 days, they're not treated in 8 days, and they're not treated in 11 days. So why is addiction treated in this manner? Putting limits so short on treatment is discrimination, especially when you somehow value one drug above another drug. My brothers and sisters who suffer from this disease of addiction, it doesn't matter what they use to become addicts. People become addicted if they use alcohol, if they use cocaine, if they use heroin, if they use benzos. It just doesn't matter. It does not discriminate from person to person according to what drug you use. You can develop the disease of addiction by using any type of minor mood-altering substance. Today, I'm not only giving you testimony, but I'm also advocating for people who share similar stories like I do, but I'm also advocating for those who are not here today because of what happened, because they got discharged after 3 days, because they got discharged after 8 or 11. Those people who went back out and used and never came back, because that's what's happening. Or what about the people who just get denied flat out? Their insurance company just says no, outpatient, there's your treatment, and they continue to use and they don't come back. Subsequently, we need regulation, and I'm grateful that my desire to enter and stay in recovery was great enough that I am able to sit here before you today to give this testimony. But it's not the case for everyone. There needs to be a final rule written for insurance companies to abide by. What happened to me, what happens to my peers, and what happened to the people who are no longer here anymore, it can be avoided, and it starts with accountability. Thank you.
Good evening. Good evening. My name's Jared. I was a corporal in 2nd Battalion, 8th Marine Regiment, United States Marine Corps. I was a machine gunner. I served in 2 tours, one in Iraq, one in Afghanistan, and 3 different military operations. In Afghanistan, I lost my best friend, of which I blamed myself, and also a young Afghani child was killed, of which I felt responsible. When I was honorably discharged in 2010, I was diagnosed with post-traumatic stress, post-traumatic insomnia, depression, anxiety, and memory loss. I was wrote a script from the VA for a bottle of Xanax to treat my anxiety. I was also diagnosed with a fractured spine, of which I received Advil, I believe. And it took a while, but after a few months, I started to feel the effects of the post-traumatic stress, and my depression and all my disorders increased. And as they increased, my substance abuse increased, and I was seeking therapy through the VA at the hospital in Philadelphia, and my doctor encouraged me to seek treatment at a private practice because she had 4,000 other patients that she had to deal with. The people who work at the VA are wonderful, however, they're restricted by their limitations. I was also told by one of my doctors that it is completely understandable of why someone in my situation would use drugs. I use that as a doctor's note to be a drug addict. It got to the point where my using got me to the point where I was suicidal, in which I spent my first treatment at the VA hospital in Lebanon, Pennsylvania for 3 weeks. We watched movies on addiction and took trips to the zoo. I was not even counseled about the effects of alcohol and addiction. I thought 3 weeks was the right amount of time for an addict to not be an addict anymore. As soon as I got out of that rehabilitation center, I made a geographical move, but continued to drink until the point where I was even worse off in my addiction and substance abuse. 3 suicide attempts later, and 4 or 5 different drugs. I found myself waking up in a hospital after a 10-day coma, and was rescued by my family, brought back to New Jersey. We knew that the VA couldn't treat my problems, so we tried treatment at the Seabrook House in Vineland. The VA would not cover any medical treatment if it wasn't through the VA, so I had to pay out of pocket. I did 5 weeks there and 5 weeks, 5 weeks there and 3 months in a aftercare program in Pennsylvania, of which VA would not cover the expenses. All in all, I believe my treatment cost my parents about $60,000, and we are not a rich family, so they can no longer retire. They had to tap into the retirement fund, and it literally took 3 months, around 3 months, for me to actually learn everything, well, not everything, but most of everything that I needed to know, and to actually start thinking clearly. VA will also, even though they say they do, will not cover emergency room visits. I was picked up by police officers one night after a mental breakdown, and took me to the closest emergency room where they gave me a pill to calm down, talked to me for about 2 hours until a family member came and picked me up, and that cost me about $3,000. It's been, I'm very thankful for the opportunity to come here. It's an honor to be of service again. Thank you very much.
As I said before, both of you have done the most important thing, and that's give a voice and a face to these issues that too often are denied because no one will stand up. No one has the courage that you both had, because let's be honest, there is stigma and there's shame related to these illnesses, and for someone to be public like you have, but you're doing it for your fellows. And that's what I love about what you've done tonight, is because there are more other veterans There are other college students who have gone through what you've gone through, and no one's going to speak up for them. But you just did. And that is the power of what you've done tonight. So, AJ, could you talk a little bit about the notion of making sure that we have comparable health insurance coverage for this chronic illness and what you're seeing amongst young people in the work that you do in terms of the challenges they face both with addiction, but the tragedies too often we've seen highlighted by the previous panel of suicide because of the lack of access to any mental health treatment?
Well, ultimately, there's really, and you said something that was just, it's right on point, and it's kind of like, you know, we're speaking out and we're trying to break the stigma associated to addiction. You know, the numbers, they just don't lie, and I just recently read a new study, and it's, heroin use is up 80% in 10 years. You know, and there, of course, is all a bunch of reasons why that's the case, but the thing is, and he touched on this as well, there's not enough treatment, and even if there is, there needs to be reform. Because watching movies in a rehab for 21 days and going to the zoo is not paying attention to your chronic illness or your disease of addiction. That does absolutely nothing for you. What we've done with young people in recovery is we advocate for young people either in or seeking recovery by removing sustained barriers to their recovery and letting them achieve their maximum potential by influencing public policy surrounding, you know, myself or other young people who are in or seeking recovery. And you know, it's an uphill fight, but it is beginning to turn a corner, or so it seems, and that is giving us hope, and that's giving a lot of other young people hope. But young people who need this treatment, they're not getting it, and it's not, even if they do, it's not the proper treatment. Like I said, I mean, 11 days in a treatment facility for myself, and I'm just happy that I was able to be here today because it's not the case for a lot of people.
You mentioned the final rule. Tell us what that final rule should look like, and if it comes up short, what we're going to be faced with in terms of all these states having to make up for that that rule that is inadequate.
Well, I think the final rule should be written and put in place so that these insurance companies are now being held accountable for what they're doing, for the discrimination against, you know, the people with suffering from addiction. You know, it's a civil rights issue. You know, if the rule isn't followed, we just continue to head down the same path that we're heading down right now. It's an epidemic. And there's no denying that anymore. And some people say it's a prescription drug epidemic, but it's not going to be for long because heroin is at a fraction of the cost of prescription drugs. And that's the corner that we've turned now and that we're heading down now. You know, people are going to continue losing their lives. I mean, that's the biggest thing is young people are dying, and they don't have to. You know, there's another way. And if they need to seek treatment and they're not provided it, the insurance companies need to be held accountable for that.
Excellent. So, Jared, you raised so many important issues, but I think the big picture issue is making sure that veterans are not having to be locked up when they get home because we don't have an adequate public health system to treat their injuries of war. And if we don't have adequate treatment for their injuries of war, you told a story where you ended up in the criminal justice system. Well, that's frankly where a lot of us with these illnesses end up, intersecting with the law. But it's pretty tragic that the criminal justice system in most places of the country is the largest mental health system in the country. The jails, the prisons are the largest. And I might just ask, you know, do you know from the folks that you serve with, if any of them have ended up having ended up with the law because of their untreated post-traumatic stress, in your experience?
As far as I know, I'm sure I'm not the only one.
Yes.
I mean, I'm facing felony criminal charges for possession, and everybody who knows me knows I'm not a criminal.
Right.
I do know that we had lost 14 Marines when we fought in Afghanistan in 2009. I think we have about 12 or 13 in the last 3 years since we've been home that have committed suicide.
You know, I always like to have sometimes a bright spot. Monmouth County Board of Chosen Freeholders did something I thought was very important. They petitioned, and through the help of the congressional delegation there, were able to set aside some property at Fort Monmouth, which they're going to be using for the homeless veterans and bringing all the services to them. So there is some recognition that there's a need for that, and it was very tough, Congressman, to get the federal government to consent to that. You know, here you have a closed base that they're not using, and here's a Board of Chosen Freeholders in Monmouth County saying, can we set aside some of that to work with the homeless? And of course, most homeless vets, you know, have addiction problems and else like that, and bring those services to them. So I think there is some movement in that thing. But I was just sharing with our panelists that you know, the stress that you come back with, that mental health issue you come back with, doesn't go away in a week, a day, or a year. And I was sharing that my eldest daughter was in a bus bombing 10 years ago in Israel where 17 people died. She was the only survivor in her area of the bus. She fortunately, God willing, had bent down and put her cell phone away when the bomb went off, and everyone else was killed. And, you know, she speaks, and she's been on the Hill to speak. She's thank God, she's alive, and she has some permanent damage, but she speaks on the behalf of victims of terrorism because there's not enough of that. But she's under treatment 10 years later. And if we couldn't afford to help her, you know, I don't know where she'd be. So it doesn't go away overnight or over a year or 2 years. It's a lifelong struggle. And I think that's the problem we all talk about here. These are lifelong struggles. The two of you understand that better than I do, but it's a lifelong struggle. Yet in the same place, my youngest daughter has something called JRA, juvenile rheumatoid arthritis. And she takes medication through infusion. The cost of her medication and her doctors, probably on a yearly basis, and she's 15, probably run between $25,000 and $30,000 a year. Yet, with an issue like this, it wouldn't run that much, by the way. Would not run 25, 30. We ignore it and say, you're going to get better by yourself. So that is where we talk about that balance of what the real life is about and what people like this and someone we owe our freedom to that served our country, or a young man who's in college struggling that we owe a lot to because he overcome that, how little would have taken dollars and cents-wise to help him. That's that big problem.
You know, we're so defensive when it comes to how much money we cost the system. But if we had leukemia, do you think we'd feel this defensive? We'd treat the illness. If we had any other illness. So I just want to thank you for raising this issue. Many veterans are going to be faced with needing these services. So if the final rule on the mental health parity does not cover that scope of service, as Carol mentioned, then what that means is those services necessary to treat their injuries of war are not going to be there. So that's why this is about parity and making sure our patriots get the care they need, because this parity rule is going to affect our patriots as well, as evidenced by your testimony. So I thank you both for your presentations, and once again, thank you for testifying.
Thank you, sir.
Kristen and Larry, could you come forward, please?
Hello, my name is Kristen Heckroth of Whiting, New Jersey, and I'm here to talk tonight about mental health insurance parity and why it is an absolute necessity. The truth is that according to the National Institute of Mental Health, 1 in 4 people suffer from mental illness in a year, which is a veritable epidemic. I'm one of that 25%, but I'm lucky. If I were to be restricted only to the care afforded to me by my private medical insurance, I would not be able to speak to you today. I'd be in a hospital, over-medicated, on the streets, or I would be dead. I began being a consumer of mental health services at only 8 years of age, and I first-hand experience with the discrimination that currently exists in health insurance coverage. I've had private insurance all my life, and I've so often been denied treatment or been subjected to subpar treatment that I currently work with a psychiatrist who does not accept insurance. As I have said, I've experienced symptoms of a mental disorder, a biologically based brain disease, since I was 8. However, it has been in my adult life that I have been the most severely ill. Despite having been in treatment all of my adolescence, I stopped therapy and medication when I no longer lived at home with my parents. After relapsing severely at 25, I knew that I needed to return to the doctor. As a child, I had gone the traditional route and seen a psychiatrist for both medication management and my therapy. However, living on my own and supporting myself, I felt that I could no longer afford to do this. So I called Aetna, my PPO, and they referred me. They referred me to a practice that offered both medication management with a psychiatrist and therapy with a licensed social worker. So I went off thinking I would receive the same level of care that I received as a child. I was wrong, and this nearly cost me my life. Whereas as a child, I had seen my doctor weekly, sometimes semi-weekly, I now saw the psychiatrist for about 5 minutes a month, and I saw the therapist for about 30 minutes every 2 weeks. Furthermore, I quickly learned that the providers who are in-network are, generally speaking, inexperienced and should not be treating people with serious mental illness without further training. I was told by my therapist that despite her having been in practice for nearly 20 years, she had never worked with anyone with psychosis before. She clearly lacked the experience of treating people with serious mental illness, yet she didn't refer me to another provider. She continued to treat me. I had a similarly horrifying experience with a psychiatrist who had been so poorly trained that she prescribed for me a medication with clear contraindications for schizophrenia and schizoaffective disorder, which I have, because it causes psychosis. I have only been hospitalized 3 times in my life. 2 of those times were in the 9 months that I treated with these people. Never before having had to deal with a managed behavioral health care organization, I didn't know there were limits placed on how much care you could receive in a given year, let alone a lifetime. First, I was told I could only see my therapist so many times a year. Then, while in the midst of a severe psychosis, I was informed by the hospital that my insurance would no longer cover my stay. The hospital's solution was to get me charity care. When I explained my situation and my very meager income, it still made me ineligible, so I was released the next day. I was minimally functional because I could not pay for the hospital privately. Thankfully, while in the hospital, my mother reached out to find me a new doctor, but what she found out took us all aback. The best psychiatrists do not accept insurance at all. Currently, I pay $285 every week to see my psychiatrist, and I'm only reimbursed $100 for my insurance. That totals nearly $10,000 a year out of pocket every year for the rest of my life. To look at it in another light, this is almost what I collect in a year on Social Security disability. I have literally no disposable income. However, in the 5 years I've been working with my current doctor, I've not been to the hospital or PASS or the crisis center, even once. And I'm now interning part-time in mental health advocacy and about to transition off of Social Security and back to full-time work. So I ask you, why is it that behavioral health insurance parity is not enforced? Why is it that in order for me to receive the best in care, I have to pay nearly $10,000 out of pocket, whereas if I had cancer, I would only be paying copays. Why are there limits placed on the care that I receive for an illness that I will have for the rest of my life and that I was born with? It is for these reasons I'm asking you to join me in fighting for insurance parity and for mental health care, that equal footing is provided for biologically based disorders that affect 1 in 4 of us. Thank you.
My name is Larry Redmond. I serve on the Middlesex County Local Advisory Council on Alcohol and Drug Abuse. My wife serves on the Middlesex County Mental Health Board. We are both college graduates, and even with our varied abilities to articulate our needs, it is next to impossible to navigate the mental health and substance abuse insurance system in our state. We have spent torturous hours speaking to insurance personnel who have little or no knowledge of clinical issues in this labyrinth of complicated insurance procedures that block the path to treatment. In recent years, New Jersey has combined mental health and addiction services because the mental health professionals have finally come to the conclusion that these diseases are in most instances co-occurring. Parity is not, however, caught up with thinking and evidence. You can't have it both ways. Thus begins my family's journey through the mental health care system. Our 20-year-old son was diagnosed with a mental health, diagnosed specifically bipolar disorder in his early teens. Along with the violent mood swings, substance abuse also became an apparent symptom of this brain disorder. His diagnosis was reviewed again when he turned 18 and confirmed as an adult diagnosis. A mental health and substance abuse diagnosis, both of which are debilitating and life-threatening. During this time, we searched for help and tried to locate the so-called dual diagnosis treatment program. We asked our insurance company for help in finding these facilities. The programs varied in length and skill, but one thing seems certain. No program approved by our state plan was sufficient to handle both problems. The bipolar behaviors usually got him kicked out of the substance abuse program, and as a result of his mental behavioral health diagnosis, it was a barrier to treatment. The insurance company's response was less than helpful. First of all, we have the state plan. Horizon has a pre-certification requirement. This usually means spending countless hours on the phone during the workday to get approval from them for a facility, Magellan. Every doctor and therapist we have taken my son to has recommended inpatient treatment. The policy states that he's entitled to inpatient treatment that is equal to any other illness during a 12-month period. Getting that stay approved has been the bane of our existence. Magellan's clerks have often told us that these doctors will say anything to get your money. In all the conversations I've had with Magellan, I was rarely given more than a first name. The names are never preceded by the word doctor. Imagine what would happen in a mental health facility if they had their clerical staff make treatment decisions. You rarely speak to the same person twice, so the conversation starts with, "Please hold while I pull up the notes." Then you wait while the new person gets up to speed on the issue, if the previous person even put the notes in properly. Usually you have to explain the situation over and over again. The rejection letters are usually signed by an RN. During these countless hours, I have begged and pleaded and shed more than a few tears in our quest to save the life of my son. Facilities in most cases will turn us away when they hear who our insurance company is. An in-network provider who was recommended by Magellan told me that we have the worst company in the state and that they will never agree to treatment. Despite hours of stressful conversation, begging for the much-needed treatment for our loved one, they never approved more than a few days at a time. So even after getting into a facility, you have to fight to stay there because of the unfair and intrusive authorization process. The facilities are helpful, but not always successful in securing approvals, and our loved ones wind up back on the streets with little hope for a normal existence. In 2012, my son was pulled from a Wawa bathroom with a needle in his arm filled with heroin, and he was thrown in a county jail. After 4 months in county jail, he was ready to be released on bail, or ROR, and he asked if we could find him a treatment facility. He did not want to go back to his old life. Magellan told me that because he was in jail for 4 months, he didn't need treatment, and that I would never be able to get a rehab approved. When I said he had a mental health diagnosis, they told me to send him to Fair Oaks for an evaluation, because his evaluation was 13 months old, and apparently bipolar disorder expires after 12. UMDNJ Behavioral Health in our county no longer takes any insurance other than Medicaid because they simply can't get paid. I reminded Magellan's representatives that New Jersey has a mental health parity law. They sent me a written response, which I will provide you with. And I quote, NJ Direct is a self-funded policy and is not subject to New Jersey state regulations. I was shocked that they were willing to put that in writing, so I brought it with me today. And then they went on to state that this would only cover a certain number of treatment days and it did not affect the need for pre-certification. Currently, Parity is the broken link in the chain for obtaining treatment for those with mental health and substance abuse disorders. Let's make Parity the necessary lifeline chain for those in need of mental health and substance abuse, rather than letting discrimination within the healthcare system continue to exist. The stigma associated with mental health and drug abuse is as painful as the disease itself, and the battle with the insurance industry is a life and death struggle. Mental health disorders and substance abuse disorders are biologically based disorders, yet insurance companies continue to be biased even with the parity laws. It is imperative that we win or we shall surely perish. Let me put this in perspective. All right, since we're outing each other, I'm 26 years clean and sober. In 1986, I spent 10 days in a detox and 45 days in a rehab. And I just turned to my wife, because I don't remember. I said, hey, did we have to check with the insurance company? She said, no, they just paid. So somewhere the system broke, you know. Good thing we didn't have parity back then. I'd be dead.
Yeah.
So anyway, well, let me even go further. I'm a cancer survivor, stage 4 lymphoma. My cancer came back. Lo and behold, they call that a relapse, just like mental health and drug addiction. I needed a stem cell transplant, and I spent 30 days in Sloan Kettering in New York City. They paid, same insurance company, $250,000. I never had to pick up the telephone. I never had to speak to an insurance agent, but if I want 15 minutes with a psychiatrist, I got to spend 3 hours on the phone. So much for parity, and thank you for listening.
Kristen, I just want to say that must have been a hell of an internship because you are ready for prime time, you know? One advocate to another, welcome to our ranks. We need more mental health advocates like you, and I hope to continue. I hope we can work shoulder to shoulder together in the trenches. Thank you.
I'd like to have you talk about the professional development piece of this, because both of you acknowledged in the course of your care that, you know, because we haven't paid for these on an equal basis, there's a deficit of funding that we start off with. And that means there's often a deficit of professional development and a deficit of standards that we expect in other areas of medicine. Part of the problem is which comes first, the chicken or the egg. You can't get standards and adherence to this great medical service if you're not covering it. And if there's no one in the pipeline to provide the service because there's no money in the pipeline. So what you end up having is you have the insurance companies blame the providers because they say you don't have, this or that, but they're not paying them like they would in other physical health issues. Both of you talked about also the lack of integration in between mental health. We have severe mental illness and then you have substance use disorder. Forget that the two, most of the time, overlap. And our system of reimbursement often becomes, well, you've either got one or the other, but we can't treat the other if we're treating one. And it's part of the problem we're in terms of how we address this. And maybe you could talk a little bit more about just the challenges you ran up in terms of getting appropriate treatment.
Early on with my son, when he was adolescent, young teen, we tried to get him in mental health programs because of his bipolar disorder. Well, but he smokes marijuana. Well, we can't do anything with that. He's got to be off the marijuana for at least 6 months before we can treat him with any kind of medication or anything. Now, that has kind of changed, because they're seeing. And, you were great with the jails are the new institutions, because that's what happens. My son's behavior winds him up in jail, and sometimes it's, and Senator Singer, takes a lot for a Republican to blow my socks off. and you spoke, I got my oil changed today, and I picked up a newspaper, and there was an article on the front page about the heroin addiction, and they mentioned that Toms River has one of the largest overdose rates in the state, and you were right on top of that. But, and that's important to me. It's important that our representatives understand what's going on, that they know what's happening in the community, and they know that what we're up against as parents, as consumers, as, just people. It's difficult. The stigma is just, you go out, there's ribbons for cancer, there's puzzle pieces for autism. Where's my ribbon? You think I got a bumper sticker on my car that says my son's a drug addict? Right. It's like, where do we go? We have each other. I have the people in these rooms, the people that care enough to come out, these networks of people that care enough to come out and tell their stories and share with one another what we go through. Without these support groups, we'd need mental health treatment.
That's right. Mm-hmm. That's right. Well, I hope all of those who are here, great. This is another pitch, Aaron, to make sure everybody signs up, because this is just the beginning. So I hope you all stick with us. You've come a long way to come this far. Many of you, these stories, this is going to happen, but it's only going to happen if we continue to go out there and give this kind of testimony and get more people to show up. Because what's going to change it, as the senator said, is when his colleagues see people showing up in the same numbers that they show up for breast cancer or diabetes or these other illnesses. And then Carol has, and it's in your flyer, Parity is personal. www.parityispersonal. We need more stories, and then we need to be able to have you if we want to go to do these ultimate class action lawsuits. Now, there's several out there already. The point is they're going to need people. And we're not going to know who it is and where, but this is a movement, friends. This is a movement. So we need you to stay involved. And I think we're going to take some questions from the audience, and I'll let Aaron wrap us up.
Thank you. I think that I just want to make sure that we gave the 6 witnesses that showed up today and told their stories a big round of applause. So thank you guys so much. and And Patrick just said it. You know, this is there's a growing recovery advocacy movement in this country. I'm fortunate enough to be the advocacy trainer with NCADD New Jersey. We've trained over 150 people since 2008. We have advocates in 38 out of 40 legislative districts, so we need to fill the other ones. We have 8 teams of advocates that do amazing work across this country, across this state. And the way that you get involved is visit that table out there and put your information down, and we'll make sure that you know about the next team meetings that are in your area, because Patrick just said it, it's a movement, and when you think about any movement, whether it be civil rights or women's rights, environmental rights, people were being discriminated against, there was inequality, but the good thing is that people spoke up about that, and that's exactly what we're doing today, so we encourage you to get involved. We're going to have a really short Q&A session. We're going to bring up 3 more experts on parity to kind of help with some of the questions that might be more specific to some local stuff. We have Barbara Johnston from Mental Health Association New Jersey, Candace Singer from NCADD New Jersey, as well as Deborah Wentz from the New Jersey Association of Mental Health and Addiction Agencies. So we're going to welcome them up to the stage. Yep, so if folks have questions, we have 2 microphones. We have one on this side, one on the other side. You also have 2 advocates in the back that have index cards if you feel more comfortable writing your question down. The 2 that are raising their hand, with Karen Barnett and Marvin Royal, 2 of the NCADD New Jersey advocacy leaders. So we're going to get questions started. We're going to ask people to try to keep your questions pretty short. We're a little further on the program that we thought we'd be, but we have 6 amazing panelists that are going to be able to answer your questions for you. So let's start right here.
Thank you, everybody. Thank you, everybody that testified today. My name is Matthew Wolf. I am a person in long-term recovery, having celebrated 28 years. Most importantly, I was an adolescent crystal meth addict who got treatment in the 1980s, 46 days of primary, 30 days of extended care, outpatient, paid for 100%. I'm clean and sober today. Wonderful story. I've spent the last 25 years working at Seabrook House, on the front lines in the admissions department. I am that intake worker who has gotten it from both sides, both from the insurance company and the family members. And I'm here to tell you today, and what I'm asking today is, I'm the guy that's got to point fingers, and I need to point fingers because I don't hear it. It's a very small handful in the state of New Jersey, and let's talk just about New Jersey. This is why we're here. It's Horizon Blue Cross, it's Aetna, it's United Healthcare, it's HealthNet. We know who they are. The CEO of Horizon Blue Cross is Robert Marino. Folks, we need to hear from you. I have had, in my dealings with Blue Cross in particular, which covers the most lives in New Jersey, in my heated arguments with them off the record, I've had a PhD psychologist say to me, and I quote, "We have more than $1 billion in reserve. Bring on the lawsuits." They don't care about lawsuits. They care about bad PR, which lowers their enrollment during open enrollment. That's all they care about. We've got to hit them with the stories. They have to hear all of these stories. The lawsuits, if you go under Blue Cross, you can see their financials. They're paying out lawsuits, and as Mr. Kennedy said, it's all covered up. But look at how many are still dying. We need to hear the stories. They need to be in the press. That's what I'm asking for from the families today. You've got to get to the press to hear these stories, particularly around October, November, and December. That's open enrollment for everybody's health insurance, in case they didn't know. Thanks.
My name is Pat King. I am, as they say, a member of long-term recovery. I haven't had a drink since September 2nd of 1977. Back when I came in to a 12-step program, there was a rehab on every corner. In the late 70s, there was. And I am so impressed with the panel, from Mr. Kennedy to Mr. Singer, And I raised 2 daughters in Toms River. And I saw it all around, but not with my 2 daughters, you know, but I just hope there's help for them if they ever need it. Like I got help. A long time ago, there was nothing around, and we had a lot in this. We didn't have anything in the state, but then we had a lot. How do you get the rehabs to come back to New Jersey?
As I said before, it's dollars and cents issues. We had all those facilities because insurance companies were paying 30, 60, 90, whatever days you needed. When they woke up to the fact that they didn't have to pay and nothing happened, they stopped paying, and those facilities all went out of business. So the answer is, and by the way, you know, I said I sit on the board of a mental health hospital in Toms River, a 100-bed facility. The state has closed most of theirs down. The ones they have open, you wouldn't want to send anybody to anyway. But let's just talk for a second. What's happening, the reimbursement is so poor that these facilities are struggling to stay open. Who's here now? And until you start opening up the floodgates a little bit with insurance companies starting to pay, they can't make it. It becomes a tremendous loss factor. And very, very honestly, in investment dollars and cents, these are all investments. These places are not going to put places in here not at least breaking even to make money if they're a nonprofit. You're just not going to see that. And you've got to bring their feet to the fire. You know, we had a hearing in Trenton, and Congress might be curious about this. The term nonprofit hides a lot of things. Blue Cross and Blue Shield New Jersey is nonprofit. Yet they gave $27 million to 35 executives, including $6 million to the president as a bonus. This is a nonprofit that we're subsidizing. Now, why they're saving that $1 billion is they're talking about going from a nonprofit to a for-profit and going on the exchange. And it hasn't been right to them to do it yet. But if they do that, they have to pay back the state all those years of being a nonprofit. It's going to cost them like $1 billion. So they're holding that money back for a reason. And very, very honestly, they want to have their bottom line look better so that when they go public, they get more money for the stock. So again, follow the money.
Thank you.
So, I think this senator's got it. So I would just say that, I mean, he knows where the bottom line is, and we can't afford to get distracted. So there are going to be hearings, you know, this is an issue that's every year, every time of year. You know, just the people who sign up in the back, to make that point again, we're going to be people you can call on, Senator, and the many times that you're going to need witness testimony and you're going to need people to show up so that when you have this issue, there is a crowd in that hearing room. Are you all going to be there to show up for this, Senator?
The issue was raised about reimbursement rates for facilities and reimbursement rates for providers. And just know that Patrick and many advocates worked very hard to get provider reimbursement rates included as a part of the parity regulations. So we need to make sure that, and the way we got them in there is we had a study done that showed that on average behavioral health providers are paid 20%, and I think this is conservative, percent less than other medical providers. And as a result of that, we got this provider reimbursement rates as part of this law. But we need providers to push back. We need you to come forward and say that you know that your reimbursement rates are low when they come to re-up your contract and ask you to take a hit that they're not doing on the medical side. We need for you to fight back and push back when these things happen, and you know. And that's the reason why nobody is in these in-networks. Kristen brought up that, you know, no good psychiatrists are in-network. Well, let's face it, it's because they can't get paid. And so we need to hear these stories from you, and I would urge not only the individuals and families, the providers need to step up and be able to help them document and fight this.
Just along those lines, in New Jersey, the Medicaid rate that psychiatrists get is $9 to see a patient for a medication review, and that's the lowest of all states.
And
And I will add that that was increased 100%, I think it was 6 or 7 years ago, from $4.50. Right now, there is an opportunity. The state's reviewing its Medicaid rates and a rate-setting exercise as part of the move to a comprehensive waiver with an administrative services organization. But that is an entity that will be doing prior authorization, utilization review, and using some other managed care techniques. And after a year or so, it will become fully risk-based, where there will be incentives for companies, not necessarily that that's the state policy, as it is not, but incentives for companies to make people dance through the hoops that were described in order to get approval for care. So it's very important. I always point out that most of New Jersey's Medicaid rates have not changed since pet rocks were the latest fad, and U.S. stamps cost 8 cents, and the president was Richard Nixon. So we're long overdue here. But there are more efficient and smarter ways to do certain things, but you can't squeeze water out of a rock. And at a certain point, providers want to be there and be accessible, but as Senator Singer pointed out, that nonprofits in the behavioral health care field, they have to meet a bottom line. They have staff to pay, you know, and they have their bills, and so they have to at least break even. Most of them do fundraising and many other activities to try and build on the low dollars. So I think, though, in the Federal Parity Act, rates are increased for primary care providers. There was nothing specific that said you had to increase rates for behavioral health practitioners. So I think that if we could build on that in the regulations in any way, I mean, it wasn't legislated, but that is one of the major barriers.
So we may call on you for advocacy in that regard.
But there's just two things. First of all, Medicaid rates in New Jersey are some of the lowest in the country and have been for many years across the board. So that skews the whole issue. It's a very important issue in New Jersey. The other issue you have to know is that, for example, in the 100-bed mental health hospital I sit on the board of, 40 of those beds are short-term beds paid by the state. Without those short-term beds that are subsidized by the state, we couldn't afford to be open. That's the same thing with the 18 juvenile beds for Ocean and Monmouth County. Those are all subsidized by the state. So if you take a look at mental health beds statewide, if they're not subsidized by the state, and the state guarantees the payment on those beds, it's a major problem. And that has been the real problem why mental health beds have not grown, because the best payer, really everything is subsidized beds by the state, they have not increased that. If you think about population shift in counties and no increase in beds, it's because they can ignore it because nobody complains. And what the congressman said is so right, and we're hearing this from everyone here. Because the advocacy is quiet. Nobody wants to raise their hand and talk like we talked tonight in Trenton. And nobody wants to do it. Think about if a legislator said, I don't want to go to the walk for breast cancer. I'm not putting on the pink pin. I'm ignoring all the women and everybody involved in it. They'd be thrown out of office. But if they ignore the problem of addiction, if they normally the problem of mental health, nobody comes knocking on the door and say, where were you? Why aren't you involved? Why don't you care? And very, very honestly, if I don't know about it, I'm kind of silent about it, it's okay, because nobody brought it to my door.
That's right. That's right. Well, we're not going to be silent any longer, Senator. We're going to get everybody out here.
Good evening, everyone. My name is Kurt Olson. Relatively speaking, I have 4 years in recovery, not long as some of the people here. But considering I'm 51 years old and I've been using drugs and alcohol since I was 12, for me, that's a lifetime, that 4 years. I commend the women from the parent-to-parent group. I'd like to give them a thanks, because I'm on fire tonight. It's unfortunate the stories that we have to hear, you know, for this advocacy. So when I leave here tonight, I mean, I'm on fire. I don't know about the rest of you guys, but I'm ready to, you know, really advocate for this. It's a personal story for me, and I've been a victim of discrimination twice. Back in 2008, checked in on a Monday, checked out on a Friday. Methadone for 5 days, told to leave that night, Friday night, back out using. Again, it happened at Carrier Clinic, where I was checked in on a Monday, was given Suboxone, which made me sick, so they gave me Librium for 4 days, checked me out on a Friday. So this is a personal story. It wasn't until, unfortunately, I was locked up. And you brought up the justice system involved. At 47 years old, I found myself in trouble with the law for the first time in my life. I lost a 6-figure career, taken away from my children, 25-year marriage. I lost everything. Like today, I've gained that back, and all the monetary things don't mean anything. My recovery is the most important thing. But it's basically a comment that it took the state of New Jersey through drug court, which I just graduated from 2 weeks ago, by the way, to put me into a 6-month program, inpatient, where I could finally realize the nature of my disease and realize that I didn't suffer from a moral deficiency. I suffered from a disease. And it took that time for me to be away from my children, to be locked up, to have 7 felonies on my record. Granted, I wasn't brought up that way. I was brought up with a loving, caring family. I didn't raise my 3 children that way. I was always an upstanding citizen until addiction took over. So I just really wanted to make a comment. Basically, we're all paying for my, one way or another, through our taxes, we paid for my rehabilitation. So I don't know if there's a paradox there or some type of, if we're paying through the state, through a drug court program, could there be some kind of other solution with insurance where, you know, something comes out of this where, you know, we're going to pay it one way or another. Either you're going to pay it through criminal activity, you know, I don't know. It's bigger than me, but I just really wanted to make the statement that it took me to get locked up and taken away from my children, 7 felonies in 3-year period to finally get treatment.
Now, one of the arguments we always make is how much more it costs when someone goes to prison than it would have been to treat that person for their addiction or mental illness. So the state is paying.
Hi, my name is Jerry McCluskey, and I just want to talk about providers stepping up and saying they're not getting their reimbursement. I've been in recovery for a long time now, but basically for the past 10 years. I was given the gift of desperation 10 years ago when I finally found this wonderful counselor who guided me for basically the past 10 years, but she was out of network. And my insurance company at the time was only paying for 5 sessions. So that didn't seem appropriate, so I just paid for it through my work. So I just feel really blessed, and I just want to say that there is hope. You know, keep persevering. You know, the system is kind of broken in a lot of ways, but if you persevere and keep your head up, you know, you will find your way. There is recovery, and you just have to keep hoping and praying and working through the system. Thank you.
Just following up on the visit limits that the last speaker just mentioned, because parity does apply, the federal parity law does apply to out-of-network benefits. So if a plan is not imposing a 5-visit limit, for example, on other medical conditions, that would be a parity violation to have a 5-visit limit on behavioral health visits. So you have a complaint, and if you go to parityispersonal.org website, we'd be happy to help you file it either in the state or with the appropriate federal agency.
Just for the, we're getting short on time, so for the remaining people, we're going to allow the questions if you're standing. No more questions after that, but what we'll do, if you want to write your questions down and leave them out on the table and put your email address, we'll work to get those questions answered, and I'll pass them on to Carol, or I'll pass them on to Senator Stringer to answer your questions for you. But for the remaining people that are going to ask questions, please keep it really quick.